everybody. Let's get started. We were already having such an engaging conversation between the speaker and the discussant that I, started to lose track of time. So I think this bodes well for the rest of the event today. Let me just introduce our speaker and our discussant for today, and then we'll get right to it. So our speaker, as you know, is Melani Cammett. Melanie has a PhD in political science from UC Berkeley. And I have to confess that I met her on her first day of graduate school. Since 2002, she's been a professor in the political science department at Brown University. She has way too many awards and fellowships to even mention. The salient fact about her for today is that her research broadly is on comparative political economy with a particular focus on North Africa and the Middle East. Her most recent book, Compassionate Communalism, is out this week from Cornell University Press, and it has a really groovy cover, so I recommend it. And it's about sectarian provision of welfare services in Lebanon. Actually, Melanie has 2 books out from Cornell University Press this week. The other one is an edited volume with Lauren Morris McLean on the politics of non-state social provision in the developing world more generally. Melanie's ongoing work is focused on health service delivery in Jordan, Lebanon, and Morocco. And we'll hear about some of that work today. So we're super excited to have her here today. Our discussant is Ron Kanan, who is Associate Dean for Research at Penn's School of Social Policy and Practice, Professor and Chair of the PhD program in Social Welfare, and Director of the Program for Religion and Social Policy Research. He is the author of a number of influential works on faith-based social services in the United States, including The Invisible Caring Hand, American Congregations and the Provision of Welfare, from NYU Press in 2002. And he's also done more recent work, but this is the piece that I know and sort of think of him when I think of his work. So we are absolutely delighted at this pairing today. I think it's going to be really interesting to get the perspective of people from like 2 different disciplinary backgrounds and who work on 2 different areas of the world, but who really work on very similar processes of social provision in some ways. So we'll have Melanie say a few words about her work before turning the floor over to the discussant and general conversation.
Thank you. Well, I'm delighted to be here. Thank you for inviting me. So I was told not to sort of give a big formal presentation, but just to say a few things about this paper, and maybe I'll make a few references to some ongoing new research I have as well. And I should just say in preface to all of this that the sort of framing and theoretical framing of this paper draws heavily on work with Lauren Morris McLean, which Julie just mentioned, on the politics of non-state social welfare. We have a series of arguments about the range of providers in that category and sort of political dynamics associated with them. So let me just recap a little bit about that framework and then say something about the empirical observations that I made in this paper. I'm focusing on the Middle East and a definite trend in that region, but not unique to that region, is the rise of non-state providers, what we call NSPs. And they come in all shapes and sizes. Some of you are probably familiar with Islamist social welfare provision, which seems to get the most attention in that region. I'm partly to blame for that, but not exclusively. And it's interesting, particularly in the context of the Middle East, because this is a region where after independence, roughly in the 1950s onward, a lot of governments embarked on sort of the construction of welfare models that were premised on a statist development model. Not everybody was included in the welfare benefits, but certainly the predominant developmental model was quite statist. And some of the wealthier countries, like the oil-rich countries, have quite comprehensive state-run welfare programs. So even in those countries, you see the rise of private actors, but I'm focusing more on non-oil economies that have less money to play with, and certainly there you see the rise of a lot of non-state actors. And so what I tried to do here was drawing on the framework that I developed with Lauren, make some observations about two non-oil economies, Jordan and Lebanon, which I think are interesting countries to compare because they both were carved out of the Ottoman Empire, sort of post-colonial constructions, but have very different development models, very different welfare regimes. So arguably different political consequences of their welfare regimes. And so one sort of overarching theoretical argument here that Lauren and I made is that the effects of non-state social welfare provision on social rights, and here I focus mainly on access to social welfare and the accountability of providers to the communities where they operate. The effects of non-state welfare provision on these dimensions of social rights depend on the type of non-state provider and the relationship between states and non-state actors in the welfare regime. So let me just say a couple of things about that abstractly and then make a few comments about the Jordan and Lebanon cases and how they fit into this. So basically when I'm talking about access, you know, I and I think just about everybody views access as a multi-dimensional concept involving things like financial access, geographic access, cultural access, and quality dimensions of access. You know, you can have lots of access to healthcare clinics, but if the quality is really bad, then effectively you don't have lots of access. And that's actually what my current research is focused on. In terms of the types of non-state providers, there's a huge range of non-state providers that operate in the Middle East and in other regions. And Lauren and I divide them up along a number of dimensions, including the level of personalization, so formalization, informal, where they operate. Are they locally based or are they international organizations? Are they for-profit entities or not-for-profit? And what's their eligibility criteria for accessing their services? And generally speaking, and these are gross generalizations, you know, more institutionalized, formalized organizations that are more locally rooted and are not-for-profit and have more inclusive eligibility criteria enhance access to their services. I don't think this is a terribly surprising argument. We also made some claims about the patterns of relationships between non-state actors and the state. There's a number of cases in our book that are largely in the developing world, but also we have a case on the United States and on Russia as well. They fit into a variety of different models of state, non-state relations in terms of the delivery and financing of social welfare. One model where state capacity to regulate or deliver services is pretty low and non-state capacity to do the same is pretty low is what we call appropriation, whereby non-state actors control access to state resources by credit claiming, by brokering access, and that sort of thing, patronage relations. And I've seen a lot of that, for example, in my work on Lebanon, where some of the sectarian parties I worked on sort of claim credit for services that are actually technically state services. And there's other patterns as well that we talk about here that range from more sort of conflictual or competitive relations between the state and non-state actors and more collaborative relations. So generally speaking, when you have more collaborative relations, it's better for access and even accountability. Access because you can extend the range of services, but there still will be some kind of regulatory control over the array of services provided, and so forth. So that's just a very quick summary. I'm probably confusing some of you, but I didn't want to sort of repeat everything I say in the paper. So I've tried to think about these arguments with respect to two countries Jordan and Lebanon, where I'm doing some work as part of a larger region-wide project on governance and the quality of social service provision. Again, these two countries, Jordan and Lebanon, differ quite a bit in their welfare regime models, with Jordan being a much more state-dominated model. And I mean, I've seen this firsthand. I just got back like a week ago from Jordan, where I'm working on this World Bank project on governance and health. And it's amazing how the state is involved in everything, you know, and has a lot of knowledge about what's going on the ground and so forth. And it's a sharp contrast to some of the dynamics in the Lebanese welfare regime. So the state in Jordan has consistently played a much larger role than in Lebanon in financing healthcare and also in the provision of healthcare. And I should mention that I'm focusing on the health sector here, really. And you know, this is reflected in all kinds of standard statistical measures, but you can also sort of feel it on the ground. And you know, as in any welfare regime, there are inequalities built into the system. So one of the most striking ones in the Jordanian system is the preferential access to benefits for citizens of trans-Jordanian origin, what they call East Banker Jordanians. And this is largely institutionalized in their access to services through the Royal Medical Services, the RMS, which serves the military largely. And trans-Jordanians are disproportionately represented in the government, in civil service and the military. So some of the clinics that we visited as part of this project are in parts of the country that are heavily trans-Jordanian, and literally 90% of the beneficiaries of a given clinic there would have RMS insurance and would have total sort of comprehensive benefits, whereas other parts of the country don't have access to this favorable kind of insurance. But nonetheless, even though trans-Jordanians have, you know, access to a nicer package of benefits, generally speaking, citizens and even non-citizens have access to a pretty decent package of benefits as well through a Ministry of Health program. So there's pretty comprehensive coverage, and I think insurance rates are above 75%, which is pretty high in the region. And so people have access to a big package of benefits. Quality is a different issue, and this is something I'll be working on more intensively over the next year plus. But even there's some interesting dynamics in quality improvement, which I can talk about. So this is, you know, a real contrast. Oh, one last thing about Jordan, which is that, you know, the primary healthcare network is pretty extensive. There's a lot of facilities, especially when you adjust for geography and population size. And so, you know, it's pretty public dominated too. I mean, all these primary healthcare networks are run by the public sector, and there's very little presence of things like Islamists and charities that are non-state charities and so forth in Jordan. They're there, but they're not as prevalent as you see in other countries. So the situation in Lebanon is really different. Yes, there's an important role for the government in healthcare financing. It's, you know, the biggest financer of healthcare there. But very little presence in terms of the delivery of services, and coverage rates are lower. Insurance coverage rates are much lower, like maximum 50%. And what you have is a pretty fragmented terrain of providers in the primary healthcare network that are, you know, divided up between sort of secular NGOs or charities, religious, a lot of religious charities, a big presence for political parties, most of which have a religious affiliation, the sectarian parties, which is what I've just written about, and so forth. So these are the dominant providers of primary health care. I mean, numerically, the largest providers are these for-profit sort of doctors, you know, in just about, in most countries in the Middle East, but of course these are out of reach for a lot of people in the population. And so it's a different terrain of healthcare provision and more generally of welfare provision in Lebanon, and much less regulatory capacity on the part of the state. When I was doing research there, people in the Ministry of Education or Ministry of Social Affairs or Health would tell me, we'd find out about clinics ex post facto after they were established. So, yes, there's technically a licensing system, but in practice, a lot of times these institutions would pop up without much regulatory control. So very different terrains there, and so what I've started to think about in the end of this paper is, what does this mean? What do these distinct models mean for access and accountability? Access is relatively high in both places. You can, as a poor Lebanese person, you can usually find a charitable clinic somewhere that will give you services even for free. There's a political cost that's often involved, but you can usually find some services. But the relative weight of the public versus the private healthcare sector in the health systems definitely shapes access to healthcare. And there's, not to say there isn't any discretion in the Jordanian system. There certainly is, and patronage is clearly evident in the welfare regime, but it's a different dynamic here. You're dealing, with sort of one actor you're negotiating with, whereas in Lebanon you have much, a more fragmented terrain to negotiate your access, and arguably more discretion, and furthermore, non-state providers have no mandate to serve everybody. They are not created to provide universal access, whereas the public sector in Jordan legally is. Whether it does a good job of that or not is another issue, but there is some kind of legal basis upon which people can stake their claims or seek services. So there's definitely more fragmentation in provision in the two countries. I'm starting to think about what the implications are for quality more, which is, again, I'm working on this project on governance and the quality of healthcare, and I've got a set of hypotheses about what kinds of actors are more likely to supply higher quality primary healthcare services. And right now, I have a series of surveys that are being piloted, or actually being carried out right now in Lebanon, starting last week, on this topic, and it looks like we're going to replicate them in Jordan as well, that measure quality of care and certain organizational dynamics. So I have a series of sort of hypotheses I'm trying to test about organizational features that may enhance the quality of care. But one thing that I find potentially interesting that struck me when I was in Jordan doing this preliminary work in Jordan, is that in some ways you have more pressure to provide higher quality care because you have this more competitive terrain of providers out there that in some ways are competing for clients. Not all the time, and I think this varies by locality, but you do have some competitive dynamics, and providers are aware that the next political party, let's say, is also providing services, and there are some competitive dynamics at play, and certainly their capacity to supply services, health or otherwise, that's perceived as high quality contributes to their governance credentials. So I think there's an interesting quality dynamic here that is worth exploring more. On accountability, I think the sort of comparative effectiveness of the state in Jordan is an important factor here. The state is just a more capable state and has greater capacity to go in and regulate what is actually happening at the clinic level. And one thing that we focused on a lot in this project we're doing right now in Jordan is an accreditation program that has been rolled out in Jordan since 2011 across the primary healthcare network and also in hospitals. And it's true that it was not started by the government. It was started by a sort of quasi-governmental or non-governmental organization with donor funding, but it works extremely closely with the state. In fact, you have to work closely with the state in order to get anything done. And it seems to have, from our preliminary research, it seems to have some very interesting effects on promoting accountability at the grassroots level. Because one of the stipulations, I actually don't think I get into this too much in the paper, so in a future draft I probably need to shrink the first half and expand the empirical observations. But one of the interesting things is this is a very top-down process of creating local councils for health. And so you would think at first blush this has no effect. This is sort of, a top-down kind of window dressing thing that was created that has no effect and is not really a grassroots effort to promote greater engagement with healthcare and to seek accountability. But even though it's top-down, it seems to be having some very positive effects on accountability in the health sector at the facility level and at the local level. So there are these health councils, local councils that are attached to healthcare facilities getting created as part of this accreditation process. And they're really quite active. I mean, we met a lot of these people from the community that serve on these councils and asked them about what kinds of activities they're doing and how this has evolved over time. And they're doing a huge range of activities and serve an important aggregating function to collect community demands about what kind of services they want, to understand health problems in the community. And preliminarily, what we can see is that some of these campaigns have been very effective. People are getting tested for chronic diseases much more. There's much more sort of adherence to medical sort of medication regimes and so forth for, let's say, diabetes in these communities, health fairs that are engaging people much more in their own health care. And so there seem to be some really important tangible effects that might even have tangible effects on health outcomes as a result of these local health councils. And the fact that the state has such strong regulatory capacity and is kind of helping to impose the creation of these local councils is interesting. And it's not something that I think the Lebanese state could do so easily. So there's, I think, some interesting contrasts there that have implications for access and accountability and come out of the very different kinds of welfare regimes and health systems that have evolved in these two countries and affect the experience of social rights for citizens in the two countries. So I'll stop there. Thank you.
Thank you. It was very hard to prepare for this because I didn't know what's the forum, and I was expecting Melanie to talk for half an hour. And when I entered, I was told that she's talking for 10 minutes. I had to talk the rest of the time. So I'm just kidding. So let me start by telling you, I'm originally from Israel. My experience is mostly with Israeli services, Palestinian services, and I'll make a comment about it in a few minutes. But many people that I talk about social services in the Arab country look at me and say, it's not serious. So I want to share with you a minor personal experience. I do work with ex-prisoners in this country. And if you don't know, we are the most incarcerated society in the history of the human race. And I travel in Oman. And I asked my host, so what do you do with people who are going to prison? And I was expecting that they chop their hand or they do some horrible things. He said, well, when somebody in Oman goes to prison, the government pays the family stipend, so they won't suffer financially when the person is in prison. And when they come back, they have a short period of time to find work, and then the stipend stops. I said to myself, wow, this is so different from anything that we would ever think of this country. Helping prisoner's family while the person in prison. It's so un-American. Even make the rest of what I'm saying. So, I'm impressed with Melanie's work, especially that she does it in healthcare, which is the most difficult topic of all the social services, educational services. Because the agencies that provide those services usually require people with higher level expertise and more resources. You can much more easily start a school than you can start a health clinic, let alone a hospital. So the level of resources that are needed are on a much higher level. And of course my expertise is more in social services and some in education. But nonetheless, I want to offer Melanie another way to look at the organization, the non-state organization, because this is a topic that I'm interested in for a very long time. In the Israeli context, non-state organization were viewed, and I'm talking now about 100 years back, as two types. The regular type, and you can find many of them in Jordan, are just service providers. Just organizations that are coming and saying, well, there's a need, government doesn't do it, we will do it, for profit, non-profit, some profit, is not the issue. The second type is the political organizations that do it for specifically to create their own enclave. So there's the clientelism that those of you who read Italian political science and welfare writing, we find a lot in those sections. But in the Middle East, and to some extent, starting with Jewish organization in Israel, they were pre-state organizations. I'm working with a doctoral student in Israel on the Islamic movement. And since the 1980s, they believe in the concept of the independent community or independent group, that they will provide all the services, health, education, social, that the people in the community need. Hopefully will also build economic independence. They don't believe that they can create their own state, but they can believe that they can create their own independent, autonomous community, and they need those services. And you do find it, another student of us tried to do it with Hezbollah in Lebanon, that they created basically the same idea. We will provide the people in our area with all the services, so they do not need to go to Beirut. They do not need to leave the place. And of course, like in typical clientelism, we'll have our loyalty unbounded because we are the game in town on all fronts. So some of those organizations, and especially in the context of the history of Lebanon, is creating an autonomous region, autonomous community, autonomous entities that the social services, health services, educational services are creating something that is much more than just meeting human needs, but creating the whole environment on their own. Now, in some of them, there's really an interest of creating a new political agenda. In the Islamic movement that we're studying now in Israel, they split into two groups. One group said, we have to get involved in politics. We have to send representatives to the Israeli parliament. We are not large enough that we can have a representative there. The other part said, no, we don't care about that. We have to be autonomous from within, strong from within, and we don't play the national game, we only play the local game. So even within those that create their own autonomous community, there's some that say, we want full representation in the general society, and some that says, no, we are not participating in the general society. So my point is that even when you look at this distinction, it's not as clean and pure And then when you go from one village to another, you see that the implementation of the Islamic movement is somewhat different based on the personalities of the people who are there, because some leaders are much more loyal to the general idea and some want their own local variation, and because it's a competition with another group from another village or within the village and family that is in relationship with another one. So complicated. Now, some countries, and Melani mentioned that neither Jordan nor Lebanon has oil. So that's a whole change again entirely because the resources are much smaller. I would be highly disappointed if you were to compare any of those countries to Saudi Arabia, Qatar, or a country with lots of. But I also do a little work in Dubai, and which is the weirdest of all, I would say, because 90% of the people in Dubai are not citizens of Dubai, and people in Dubai themselves are at such affluence that they don't even know how to manage it and who is to benefit from it. And then you have another 5% of very rich foreigners that either, what should I say, very rich, some very rich, some want to be very rich. And each and every one of them know that within a week they can be expelled from the country. But they develop maybe the highest level of health services in the Middle East. But it's very limited to the very rich and does not spell out to the Bangladeshi, Indian, Pakistani worker who are pretty much exploited. So, and finally I want to say that Melanie and everybody does work. Mark Stan and I are from the School of Social Policy and Practice. It's been years since we were invited to discuss, I speak for you, Mark, correct me if I'm wrong, people who talk about accessibility, quality of care. For me, it was like music because it's kind of a topic that slowly disappeared from the map. It seemed that the discourse about social services, health services, education services was saving money. How can we do it in the cheapest way, in the way that would be the least expensive to the taxpayer? Let's reduce taxes and cut the quality and the amount of services. And then I read this paper, and Melani said, well, good services have to be accessible. People have the right to say whether the services is good. They should have a say in it. And I said, wow, this has been a long time since it was part of the discussion. And sadly, I don't hear it about American social welfare services almost at all. So thank you for this, at least if not for that. Thank you.
Yes. Melanie, do you want to say anything in response to the comments you just got before we collect more?
No, I mean, but the one thing I would say is I found, maybe one thing, and it might sound a little self-promoting, but I'll say it anyway. So I found your discussion really fascinating about the distinction within these Islamist groups, I think, operating in Israel. And it's interesting because in the book that just came out this week, that's a core, sort of one of two of my core arguments is whether they're playing the national political game to get into electoral politics or whether they're sort of playing an extra political game. That's sort of one of the two main arguments in the book. And I think it leads to very different dynamics of welfare provision about who's included and that sort of thing. So it's interesting that you're describing the same thing about that organization in Israel because I actually know very little about that, but over the years people have told me you should look at the Islamist group in Israel because there's some parallel stuff going on. It's very interesting. I didn't realize that.
What's the second main argument?
The second main argument is has to do with the structure of political institutions, and when you have a power-sharing system that puts a premium on intra-community competition, so in this case, intra-sect competition, you have an incentive to cater to your own to avoid outbidding dynamics. So until you become the dominant actor in your respective community, you have to sort of, in the case of the Christian parties in Lebanon, for example, where there's a lot of competition, they have to out-Christianize each other and, you know, show how they're defending the Christian community more than the next guy.
Cool. I can't wait to hear you. Jeff.
Hi, thank you. I have two questions. One nice thing about your paper is it really illustrates the complexity of the questions that you're examining. But one thing that I found confusing, because I didn't see it discussed as maybe as much as it could be, is the difference between two ways that a state might provide welfare. One through funding, the other through the actual service, or one a state can do both. And if we're trying to evaluate the relative ability of states versus non-state providers to administer welfare, it strikes me that these are two distinct variables. And to what degree are you suggesting that non-state providers are less likely to provide absolute levels of funding? And to what degree are you suggesting that given the same level of funding, dollar for dollar, non-state providers are more or less or maybe less likely to provide the same level of access or care? It just strikes me that there are two different dimensions that you don't list as one of your, when in your taxonomy of types when it comes down to the non-state providers. And then the second question is more broad. In criticizing the non-state provider dominated regime in Lebanon, you come back a lot to fragmentation. That's because there's more fragmentation of provision of services in Lebanon, that there's less ability for accountability. Can we ever imagine a situation where the NSP model could provide less fragmentation than a state provider, or is it always going to be the case that when you have a state-dominated regime of welfare for healthcare, there's going to be less fragmentation and therefore more possibility for accountability? And if it's not imaginable that a non-state provider model would have less fragmentation, then in some sense, one of the dimensions is already solved from the outset in terms of evaluation, because we just know that we're going to get less fragmentation when we have a state model, even before we do the empirical work. So that would be the second question.
Do you want to collect
maybe I'll just, since it's fresh on my mind, and those are pretty important points, let me just respond there. So yeah, I think these are great points that I definitely don't develop here. I think they're more developed in the larger work, so I think the financing versus provision distinction is really critical. And actually, I don't think we get into that so much, but I've been thinking about that a lot, and I don't think it's in the paper, so maybe it's in our paper. Yes, that's true, it's in our paper. So you raised an interesting sort of counterfactual, you know, first of all, are they non-state providers less likely to provide absolute levels of funding? And I think in general, yes. I mean, I think it's very hard to imagine a scenario where a non-state actor has the same budget as government. I mean, maybe BRAC in Bangladesh, which is like almost as large as the state, is sort of the biggest provider there as an exception. But that's really an exception from my understanding of the terrain out there. Let's say, you know, in the hypothetical world, there was an NSP with the same budget as the state. I think that this question of mandate really matters a lot, because states, in principle, we know that things, the way they really work in real life, are never the way they're supposed to be, you know, on paper. But in principle, states have a mandate to serve at least all citizens, if not citizens and residents. So I think there's just an inbuilt distinction there that gives states the upper hand in provision. But I think actually the answer to both of your questions, to me, turns on that second variable, which is the relationship between the state and the non-state actor, which is something I think I need to develop more and clarify more in this paper. Because even if the non-state actor can never have the same level of financing or the same level of infrastructure for provision, it doesn't necessarily mean that a regime dominated by non-state providers is automatically worse. I think that's where the state relationship comes in a lot and where state capacity matters a lot and the nature of the relationship between the state and the non-state provider. You know, a lot of times you'll hear folks at the Lebanese Ministry of Public Health saying, oh, we are the future of the welfare regime in the Middle East because we have so much non-state provision we always have. We are the future, but other, you know, policymakers and analysts from the region look at Lebanon and say, oh my gosh, we hope that's not the future. And it may be the future in the sense that there's going to be more and more non-state providers, that public welfare infrastructure is crumbling in Egypt, in Tunisia, in all kinds of places that had pretty robust public infrastructure. But the difference is that, you know, you may have more capable states that are better able to regulate what's going on in the non-state provider. So I think it's not that we can automatically say non-state actor-dominated systems are more fragmented and therefore are automatically worse. I think the answer would have to depend on the nature of the relationship with the state.
I'm going to jump in first, and then you, and then you. Yeah. So
Can I suggest that we have Melanie, let's move around a little so they're back in part
Melanie, do you want to come up and take the podium?
Oh, okay. I'm going to bring this up here so I can write all of your interesting comments.
So Melanie, my question for you is as your editor.
Okay.
So I've really been thinking about the whole series of talks that we've had this year in a sort of Marshallian framework of thinking about social rights. And you focus on access, which is sort of core to the Marshallian framework, but you also talk a lot about accountability. And accountability is not something that Marshall really talks about as such, but I think he could be made to talk about accountability because his whole point is about how social rights and democracy fit together. So I wanted to ask you to do my work for me and to try to make a case for how we could integrate this idea of accountability into the broader framework of social rights as articulated by Marshall. Sort of what does accountability really tell us about the substance of social rights? Why is it a necessary component of social rights rather than just something that we like to have? That's why I'm asking you to do it.
Maybe I should take a few questions, that way I can...
That way we can avoid this one. All right, that's good. So the young lady in the pale green sweater.
Hi, I'm Sara Murad from the Annenberg School for Communication. I'm really excited for the book. It's been a while that something has been published on Lebanon specifically.
Are you from Lebanon originally?
Yes, and I work on Lebanon as
Wow,
well.
okay.
And I have two questions. One is this very small one, quick one, and it's if whether you have a historical kind of angle and to contextualize this, consider the role of the missionaries in setting up this kind of the provision of the non-state provision of social services. And the second and the bigger question, I think, is so I'm grappling with this question, and it's, can we really talk about them as non-state actors? And why are we assuming a certain separation between state and civil society that, particularly when we're talking about the sectarian parties and the religious establishments, if we consider the person in status laws, who's running that, and then even the electoral law and the system of representation, the appointment of ministers, the overlapping economic/governmental. So if you look at Solidar, the real estate company that reconstructed Lebanon, so the prime minister is also the owner of that. He's also the person who donated the biggest governmental hospital. So to what extent really is this a non-state actor?
Let's take one more, the gentleman in the back.
I guess my two questions, one will be related to the health system in Jordan and also geopolitical. King Hussein's wife is very proud of the money they put into cancer research and their hospitals in Jordan, etc. She also said we will never turn away any of the refugees that have come into Jordan if they need cancer treatment or emergency care. Given the fact that our government through the government in Iraq and also wants to overthrow the government in Syria, those two countries have sent hundreds of thousands of refugees into Jordan, including many Islamic radicals who are challenging the government of King Hussein. One, do you think that the refugees coming in there could bankrupt the medical system in Jordan? And secondly, do you think that our Mideast policy could have the unintended consequences of having one of our staunchest allies in the Middle East, King Hussein, overthrown internally by all the refugees that have crossed the border there, including a number of very militant groups that are in Jordan right now that are very anti-King Hussein?
All right, well, I guess I'll start backwards. So, I mean, this is a huge issue, health financing, and the public portion of healthcare financing in Jordan is going through the moon, and it's unsustainable. It's not unique to Jordan, but it's a really big problem there. The refugees are only part of the story. A lot of it has to do with, extensive government coverage of services, including for non-citizens, and also the sort of increasing sort of technological sophistication of services that are very expensive on the budget. So this is a problem, and this is a major focus of the government's initiative now in the health sector. That's actually part of the reason that this World Bank team is working there, is to address that. And fortunately, it seems that they seem to be aware of the importance of building up primary care as part of a broader strategy of reducing costs. So, the refugees are a huge strain. They're handling it quite differently in Jordan than, say, Lebanon, where they are not put in camps in Lebanon. And in Jordan, not every refugee, anyone with any kind of financial means is sort of renting an apartment and so forth. But there's a lot of refugees in camps. There's been a fair amount of coverage of that. So those refugees are getting medical care in the camps, and they actually can't move out of them. There's restrictions on their movement. But it's certainly a big financial strain on Jordan, on Lebanon, and all these countries. And it's been a problem for my research, which of course is the least important consideration in the world. But I'm not trying to say that's the most important thing. But it's been a problem because, the health centers that my teams are going into and running surveys are just overrun with refugees, and so there's tremendous strain on the facilities and on the doctors' time, et cetera, et cetera. So it's really a big issue. I don't think that's by any means the only reason why there's a financial crisis in the health sector there, though. I also don't think the refugees would be necessarily the reason why you see the monarchy, King Abdullah, overthrown. I don't know that I see that in the near future. In fact, I'm going to strike that from the record and not engage in prediction, because probably tomorrow something will happen after I've said this. But there's definitely dissatisfaction. What's really interesting about Jordan is I've mentioned these Transjordanians as, privileged in the welfare regime and historically quite privileged in general. But a lot of the grumbling and dissatisfaction with the monarchy right now is coming from exactly those people. So that is very striking in Jordanian politics right now. They're the ones that are more often engaged in strikes and so forth. And I think part of it has to do with cuts to the public sector where these folks have historically been employed. So, the public sector decline directly affects the political backbone of the regime. And so moving to the question about Lebanon, I mean, definitely in my book, again, self-promotion here, read the book. There's definitely a historical contextualization. There's a whole chapter on the welfare regime and its origins where I mention that stuff. I don't go into great detail on it because there's published work on it, but I cite all of that. And I think you're absolutely right about making this sharp distinction between state and non-state. I do the typical social scientist thing where I sort of acknowledge the blurry boundaries, but then go on and do it anyway. But it's when you're talking about welfare, it is fuzzy because certainly all of these parties, even the ones that have the largest resources and their own networks, are cannibalizing the state and profiting from state resources and trying to get into the state. But some of them run their own completely independent welfare networks, their own schools, their own clinics, their own hospitals, and that sort of thing. So those elements of their projects you could call non-state, but absolutely, I mean, it's all sort of overlapping. And then there's lots of charities and so forth that ostensibly have no connection to these parties or to the state that I think are more deserving of the label non-state, but even some of those, as you probably know better than I, are effectively controlled by some of these political actors. So there's some of the most prominent religious charities that look like purely religious charities are actually either controlled by or heavily influenced by some of these parties. So it is a blurry category. I'm going to have to get back to you on that one, but I think I'm taking this as a suggestion for further elaboration in a refined draft.
All right.
But I do think, okay, just one quick thought pops into my head. If we think that access involves things like quality or culturally sensitive provision of services or any of the other dimensions even, I think accountability has to be part of the story because, arguably providers, many of them won't improve quality in the absence of pressure from beneficiaries to provide better services or it's one channel by which quality might improve, and that's a dimension of access. So I think there's ways that accountability would affect those core sort of Marshall access type variables that make it arguably important to the concept of social rights. But I certainly would have to think more about this, and I would welcome suggestions. It looks like it looks like there were two fingers there. Is that on the, okay. Guy?
So I also want to push a bit on the accountability, but from a different angle, Julie. So especially given that you're looking at non-state actors, so to the extent that you're looking at almost accountability is something that we tend to associate more with the state, or with political accountability. So the question is, what is the accountability that you have in mind? Who's accountable to who? So if I'm a private provider, am I accountable to the community? I don't know. So with the state, we assume that as a state actor, we can't deny services to people. But if I'm a private provider, if I'm a political party, if I'm just an NGO, do I have the same level of accountability as a state? So the kind of question, especially when we think about accountability as a citizen in a kind of a principal agent framework, who exactly are the principal and who exactly are the agents in the way you're thinking about accountability? It's not clear to me. So it might be there is an accountability relationship, but it's really not about the level of the unit, but it might be the local government that supervises the clinic, so the citizens might hold the local government accountable for for not making sure that the clinic is doing what it was supposed to do according to some regulation or mandate. So that might be the accountability relationship. I don't know. The point is, like, it's not that clear. So one of the things I would like to see kind of going forward is kind of thinking, if you want to maintain the accountability framework, kind of thinking a bit more carefully and making it much more transparent, who's accountable to whom, and what are you accountable for? What's the kind of putting some content into the accountability relationship.
Roger?
Well, I have just a factual question, but it plays into who gets served by whom and why, in that I may just not have read carefully enough, but the portrait of Jordan says 75% of people have health insurance, and that it's structured, the quality is structured along national lines. Transjordanians have the best. But we also read that the state provides universal access to health care. And so I'm left confused. Who are these 25% that don't have health insurance? What does that mean for the provision of health services to them? Do they get it from the state anyway? Are there people being served by the kind of enclave services that Ron talked about? Can you tell me about that 25%?
So I have a question regarding state capacity and accountability. You say that state capacity is the ability to regulate and sometimes even to deliver social welfare. And then later on in your piece, describing the general context of welfare provisions in the global south, you mentioned the fact that very often welfare delivery is predicated upon strong kinship networks or social networks broadly defined. And then finally, there is a piece in the paper where you are talking about how states have often legal obligations to deliver public services. Now, if you look at this, if we take this discussion on accountability, and we're talking about the state's ability to regulate the delivery of public services, the question then becomes what institutions of the state, especially in authoritarian contexts, are capable of ensuring accountability or regulation of public services. If you're looking at this, is there an organization other than the organization which is supposed to deliver public health care, which is then going to ensure accountability? Is there, for example, if you're talking about a legal right to health care or some legal obligation on the part of the state, is there a judicial system ensuring service delivery in these cases? If there is not, or if in this case it is problematic, why should it be then that the state is more accountable if non-state service providers, which may be predicated upon kinship and group networks, which could then provide accountability, are seen as somehow not as accountable as a state, which you mentioned in your paper, because there is no requirement for it. It's probably a less coherent attendance to the question that has been asked before.
Okay. I'm not sure I totally understood your question. So you're saying, why should the state be more accountable if welfare is provided by non-state actors, and many of them tend to be along kinship lines? So should we expect the state to be accountable?
Yes. So if you have a condition where the state is not capable, and a lot of relationships are based on kinship, religion, the caste or whatever, then you may have a situation where these non-state service providers, who are based upon these traditional systems of traditional networks, which are enforcing their own form of accountability, are in fact more accountable than the state, because the state does not have stuff like a constitution or a judiciary, which is then enforcing accountability upon the state.
Yeah. I mean, I don't think I would, I think actually that's sort of almost a point that we make, so I don't know that I would disagree with you. I would actually say that that statement is sort of the starting premise of a lot of the work that I've been doing. So yeah. So why should we expect a state to be accountable under those circumstances when it lacks capacity, when people are more organized under these lines? I don't think the world looks that way the world over, but there are a lot of places that look that way, and certainly the places I've done in-depth work look like that. So that's been kind of the starting premise of what I've been doing is, you know, why should we expect the state to be accountable or to provide effectively or do all these things when it's weak, and when you know, there are these alternative lines of political order that people are involved in. I think there's consequences to that situation that if we shift into normative terms are disturbing in a lot of ways. And actually I spend part of my conclusion talking about that, what that means for equality of access and so forth. But yeah, so I unless I've misunderstood you, I actually would just say I agree with you, and I think that's an interesting point, and I think it's sort of a starting point. So the factual question that I think relates to the dynamics of accountability and provision about Jordan is, so from what I understand at this point, the formal insurance is limited to approximately 75, maybe a little bit more, closer to 80% of the population, through various vehicles like this Royal Medical Services, which only really serves members of the military. And they tend to be almost exclusively trans-Jordanian. Then there's this Ministry of Health coverage, which, and then a variety of other vehicles like this civil health insurance program and so forth that cover most people through one form or another, but some portion of the population doesn't qualify for the poverty, means-tested programs and isn't in the civil service of some sort. So those people would be left out. I have to confirm this, but I would imagine a lot of them are Palestinian origin because by and large, it's not exclusive, this is not 100% true, by and large, Palestinians are not staffing the civil service and or Jordanians of Palestinian origin, I should say, are not staffing the civil service and the military and so forth. But they still can go to these clinics, and one of the things that we pay a lot of attention to when we go to the clinics is the fee structure and what's posted and all that. And so a lot of these people, this 75 to 80% of the population, goes in and actually pays nothing, or pays some small amount. And then those folks that don't have insurance go in and pay more, but it's still a really, really small amount. So obviously that can matter a lot if you're poor, but the very poor that are citizens can benefit from the civil health insurance program. So there's some portion of people that don't fit into any category that are those folks that might go to these clinics and pay the extremely small amount. We asked at some of the clinics we went to, how many people today and how many people yesterday came in here and didn't have any insurance? And there was, at one clinic, I think there was something like 100 plus clients or beneficiaries that day, or patients, and 1 or 2 did not have insurance. But these were areas where, like Ajloon or something, where you have a lot of military employees, and a lot of people are benefiting from the RMS program. But the difference is also the package of benefits you get and the quality of care. So there are facilities that are exclusively for the Royal Medical Services, which are the ones targeting the military, and they're just considered higher quality. Originally when we were going in to do these preliminary quality assessments of facilities, they wanted us to go just to the RMS facilities. So you can imagine why. So this is a really good point about accountability, and if we're looking at non-state actors and why focus on accountability, a concept we usually associate with the state, of course. This definitely needs to be fleshed out more, and I think concretely in these cases as well would be helpful, and not just in abstraction in a revised version. So I do think there is accountability for non-state providers related to the quality of care, the experience of provision. I mean, I can imagine that accountability is a concept that is applicable outside of the public sector, in that you are a patient, you go to a healthcare clinic, you get horrible service. There should be a feedback mechanism whereby you can say, I didn't get what I paid for, and that sort of thing. So there's that kind of, I guess, narrower concept of accountability between provider and patient. And there's certainly some of that going on with non-state providers. I don't have a lot of empirical hard data on this at this point, but there certainly is some of this going on. And in my survey questions, I have a whole battery of questions about how patients were treated and how they provide feedback and all that stuff, and what are the feedback. And also, not just accountability from patient to provider, but accountability within the organization, like do staff members have ways to transmit preferences and grievances and that sort of thing. Because there's a literature in the healthcare delivery, in studies of healthcare delivery that focus on workplace dynamics and how that affects quality of care. So that was interesting to me. So I think, we're talking about a narrower concept of accountability, but certainly also there is this kind of boomerang accountability that you're describing, whereby people in a community go to a facility, they have a bad experience, they, should be able to go to their local government that then says, you need to be doing this to the facility. And so in that form, I think a Jordan type of model where you have the state that's much more cognizant of what's going on at the local level, much more in control, exerts much more social control, is hypothetically more capable of performing that kind of accountability. And whether it does that is another issue. And this accreditation initiative that's going on in Jordan now actually seems to be setting up mechanisms that don't operate from patient to local government to facility, but bring the accountability directly from patient or community member to facility through local health councils that are composed of elites in the area or folks with expertise in health in the area and so forth. So they're setting up a different model that doesn't go through the state for accountability. But I think your point is well taken that it's not very clear.
Ian,
Yeah, something that I noticed that I was thinking about was another institution that sort of mediates both the public and non-public division system, but also can be involved in availability and accountability, which is things like national medical associations, doctors clubs, healthcare worker unions. In Egypt, where I do my field work, there's been a sort of rolling doctor strike going on for 3 years now, which is making demands that could be built into that larger model of accountability of both the government on the investment front, but also things like safety in hospitals and physical security and other issues. And I was sort of wondering, are those kind of institutions present in Jordan or Lebanon? And if not, that may be interesting in its own right as to why, and to what degree they may be completely affiliated with the government or have some role, independent role, or be totally independent.
any other questions out there? Yes, Julia.
Thank you very much for the paper and for your presentation. I'm struggling a little bit to understand the explanatory logic because accountability is something that you measure at the individual level, whether individuals tell the authorities or whoever is responsible accountable. However, it seems that your explanatory variables are all system levels, whether you have a high state capacity together with a high state in the high capacity non-state provider or low. So the four different universes seem to shape accountability. But I don't see the connections. I don't see how we go from, we are in the appropriation or in the co-production universe, and this affects my accountability differently. And I'm going to illustrate this with an example. I assume that in all cases you're working with fragmented healthcare systems, correct? You don't have any universal, exclusively public system where there are non-state providers.
A system where everybody has access that is provided by non-state providers.
Well, no, you don't have a case like the UK where it's all public, correct? I mean, in all your cases are fragmented healthcare systems where you have public providers, private providers, perhaps social security providers, sectarian, providers, and you go on and on.
Just to be clear, many of the private providers in the UK are private,
Well, that would be a very interesting case to have, because because I wonder to what extent you could apply. I mean, what would be the capacities of the non-state that you're interested in measuring? Are they the same in a system that is exclusively, universal public versus one that is a fragmented system? Let me illustrate this with one example. Perhaps it will be clear why I'm having very, very hard time linking what makes people, claims of accountability different depending on the type of universe they are, one of these four types. In Brazil, you have a fragmented healthcare system, but with the constitutional right to healthcare provision, a right to healthcare coverage. So what this has created is for the middle class, for anyone strategic, they will pay a small fee to get preventive care, to get, clinic patients visits that are relatively inexpensive in the private sector, but then they don't have to wait. They go to nice facilities, everyone is smiling, you don't have to, deal with decrepit, falling down buildings. But then whenever they have to do something that is high complexity and very, very expensive, like an operation, they will go to the public hospital. So there is this division in the provision of healthcare services that is very important to who is to be held accountable for what. So in that case, you have local councils, you have local health councils, which by the way, it would be very interesting, perhaps a case to compare, because they were created in the 90s and mandatorily imposed in all localities, of which there are 5,500, so there's lots of variation, in 2000. And they all now have them because they're requisite to get federal transfers for local health expenditures. But what is discussed there is, the public sector. No one holds the private sector accountable. If you don't like it, you move to another provider. Perhaps, you can, have a lawsuit for malpractice, but there are no other mechanisms for accountability. It's the public sector that is being held accountable in the local health councils. So, when you were talking about your local communal councils, I was very curious to learn more about how they work in a system where they're not part of a public healthcare system. And actually, in the organization of the health council, I would decide often, sorry, this has been kind of a long intervention, but in the case of Brazil, it's very relevant that this is part of the public healthcare system, because the way in which the councils are organized, which is very important to representation, which is another very important issue that these councils bring about, if one wants to think about accountability, is that they have to be half civil society, which is defined according to organized organizations that must be in a roster, that must be pre-approved. A quarter doctors and a quarter bureaucrats of the health system. So it's very clear who is being represented in those councils. When you have local community councils where anyone can participate, I pose a question of whom they are representing, and who is that? Going a little bit to Guy's question, who is that? Is doing the demand for accountability to whom?
Yeah, I think there's a common theme here, which is important. By and large, I would say that my argument with Lauren and something that's come out of my work is that you get more accountability, but it's a more public-dominated system. So I think it kind of fits with what you're saying, that there is actually less accountability when you're getting your services from non-state providers. So much more the case when the state is not capable of regulating them very much. So that's where that state non-state thing fits in, the relationship fits in. Let me go back. So okay. So I don't have like a national health service case in Jordan and Lebanon. Certainly not. There's some of the Gulf systems, which I don't think are worth exploring here, are closer to that, but even they're getting more privatized now. But Jordan is you know, a much more public-dominated system, so it's not a national health system kind of model, but for poor people, it can sort of look like that. So, but, you know, as I mentioned, the largest sector and fastest growing is the private sector, even in public-dominated Jordan. So I think you're right. I mean, there isn't as much accountability there in the sense that people kind of vote with their feet. When they don't like what they're getting, they go somewhere else. And in another sense also, which is the state has less control over the private sector as well. When we would meet with state officials and try and figure out licensing procedures and regulatory procedures in public clinics, it's a very different picture when it comes to the private sector. They just have less control over it. And it's even worse in Lebanon, really much worse, to the point where it's basically impossible for me to run my surveys on including for-profit private sector clinics, which I really want to do because some of the things I want to test have to do with compensation mechanisms and so forth and how they affect quality. But the only way I can get into any private sector facilities if I go through the outpatient departments of hospitals that have a relationship with the Ministry of Public Health. But it's impossible just to show up at a private for-profit clinic and say, oh, we're going to run these surveys that test the medical knowledge and capabilities of your providers. So, you know, like, get out of here. So I think you're right that, and this comes back to your point, that we're just talking about either a different model of accountability or really almost no accountability in the sense of provider to patient when it's a for-profit scenario, because most of the time it just happens with people changing their providers. I do think there's something different when it's a different kind of non-state provider where the provider is more embedded in the community and there may be kin ties or religious ties or whatnot. And in some ways the accountability is quite bad from the perspective of the patient because you're in a power relationship, a patron-client relationship. So it's quite bad. But it also depends on what kind of client you are. If you're like a real activist in an organization or really active for an organization, you're going to get more accountability, better care, and so forth. So I think there's variable relations with the provider depending on who you are in those kinds of situations. So your larger point is about, you know, I've got an individual level relationship with accountability, but yet I'm talking about system-wide factors. I guess the way I'm thinking about it, maybe I'm not understanding your point so well, is that these different institutional configurations that lead to different worlds, different systems, create different possibilities for accountability. So I don't know that I was getting so micro, maybe I should get more micro, but that I would say, you know, this is necessarily how this world plays out for this set of individual relationships. But I do think those different configurations of state, non-state relations and the additional variable of what kind of non-state provider are you create different possibilities for accountability relationships. So that's how I was thinking about it.
Melanie, we are at 1:30, and I know a lot of people may have to leave, but I do want you to take a moment to answer Ann's question.
Oh, yeah, I'm sorry. So just on the point about these other important actors like unions and doctors associations and so forth, mostly in my research where they've come into the picture is that they block regulation and that they don't want more regulation of what's going on in their clinics and activities, more stringent licensing procedures and so forth. So that's how they've come into this more in the way I've encountered things so far.
Thank you.